thank you very much, respected Dr. Shada Jain ma'am, chairpersons and Delhi Gynae Forum. Thank you for having me here. It's wonderful to be in Delhi. I've been in Delhi so many times, so it's always wonderful to be here in the presence of so many distinguished senior OBGYNs. I'm here to talk about a boring topic, which is PCOS, and you've been hearing about it for at least 30-40 years. Hopefully, I'll try and put some fresh perspective on it. One thing I've realized over the past 30-40 years that I've been in medicine is that we as doctors are lifelong students. Whatever I say today, maybe 6 months later will be out of date. Whatever I'm saying now is definitely very different to what I used to speak 15 years ago. And as Hippocrates said, the art is long, life is short, and we need to continually update ourselves, not only because science is advancing rapidly, but also because we would like to offer better solutions, better options to the women who come to us seeking help, and we should be able to guide them in an evidence-based fashion at the same time. It should not be driven because Dr. Pratik Tambe is saying something. It should be because we want to give better options to our patients, treat them in such a way that they have not been treated earlier, move away from dogmatic Gisapita medicine by rote, which was inculcated into us in our medical college days, and try and imbibe some of the more modern evidence-based practices which are now prevalent in the West. Whenever I speak about something, I like to start by saying, examining whether the subject is clinically relevant or not. You don't need me, and this is a very august audience, you don't need me to come and tell you that PCOS is exploding worldwide, not least in our country. These figures are hopelessly out of date. They're from before the pandemic. I'm pretty sure that these numbers will have multiplied at least twofold or threefold if we were to do a census in today's world, and there is one happening next year itself. I was discussing with Shada Jain madam just before we started the program that maybe in the census we can incorporate some of this data. It's a pipe dream, hopefully it will happen. What I want to stress is that PCOS, what we see today, is very different from the, in inverted commas, PCOD, which I studied in the 1990s as a medical college student. And if you look at the old textbooks, Spiroff in particular, that we used to consider as the Bible of endocrinology, the concept of PCOS had not come then. It used to be called PCOD. And primarily it was women who were seeking fertility because of chronic oligo or anovulation who used to present to us at a particular time, maybe around 20-25 years of age. Today, 35-40 years later, PCOS has morphed into something else. You know, in Greek mythology, there is this monster called Hydra. You cut off one head and 5 new heads grow. So PCOS has now morphed into a completely different monster, and it is ubiquitous right across the reproductive lifespan of a woman. So much so that now today, because of the Barker hypothesis, we'll come to that eventually in a few minutes, children who have not even reached puberty are presenting with features similar to polycystic ovary syndrome. So even this slide will become out of date once that data starts being collected and being published. The HRA guideline, which was published almost 2 years ago in collaboration with ASRM and the Monash University, is what guides us. We will have a revision to this very soon, and if you are not aware, the disease what we call PCOS today, and which we used to call PCOD when we were medical students, will have a completely different name maybe 6 months to 1 year from now. There is a trend, there is actually a survey which is going on, you might have seen it in your social networks, on WhatsApp and on email, that a new terminology is being proposed which is going to completely replace this PCOS syndrome terminology which we are very familiar with. And of course, then this guideline will also have to be updated, and this will also become out of date. If you're like me and you fall asleep midway through reading 200-page guidelines, then this is a very nice summary paper which lists out the most important recommendations from the guideline for clinical practice. In case you're not aware, that's the reference at the bottom. You can look it up, and that will help you as an easy, simple, ready reckoner, especially if you have juniors or students or trainees and you want at a glance to be able to tell them what is recommended by the guideline and how you proceed in an evidence-based fashion. The modern classification has made life a little bit simpler for us. So there are 3 standard pillars which we talk about. Hyperandrogenism, which means acne and hirsutism. That's the fancy clinical terminology for it. Oligo or anovulation, which all of us are most familiar with because as OBGYNs we treat fertility problems. And there is the ubiquitous PCO morphology on ultrasound, the criteria for which have been clearly laid down and revised periodically. Combinations of these give us various different clinical presentations or manifestations. Again, the sophisticated terminology for that is phenotype. Okay, it will ring a bell. And this phenotypical classification has far-reaching implications because it helps you to determine at a glance what are the most important concepts that you and I as clinicians need to tackle in a patient at any given time. And we are also able to counsel that woman as to what the long-term implications of this diagnosis of PCOS is. Some more recent advanced concepts which have come to the fore, especially in the past 1.5 to 2 decades, and that is actually why PCOD became PCOS, is that there are a lot of metabolic issues which are beneath the surface. Now let's be honest, we are OBGYNs. We primarily deal with deliveries. Besides hypertension and diabetes, we don't understand too many medical disorders. And many of them we studied during pregnancy. Metabolic complications like fatty liver, NAFLD, all these concepts were not known when I was a medical college student. Okay? These have come only in the last 15 to 20 years. And they have come because we are now recognizing that besides the standard teaching, there are 2 important issues which are there beneath the surface and which we have now begun to understand with greater frequency in our own population. One is that there is a chronic inflammation which is happening, and secondly that there are a lot of other metabolic issues which we as OBGYNs don't always recognize, for which we need to have a multidisciplinary team approach. We need to take into account other specialties like internal medicine, maybe an endocrinologist, dietitian and nutrition so anyway is with us, and that is how we'll be able to do justice to these women in the right place at the right time, so that we ourselves are aware and we can communicate this to the woman in question. This chronic inflammation which is there is actually one of the basic principles or tenets, if I can say, for what we used to call in the old days metabolic syndrome. Now, those of you who have studied Spiroff in the 80s and 90s will remember that we used to be taught that after 15, 20, 25 years of unopposed androgens and estrogen, women will develop metabolic syndrome. Unfortunately, that is no longer true. We are now seeing young girls who are maybe just 15, 16, they are still in school and college, who present with 2 out of 3 criteria or even 3 out of 3 criteria which satisfy metabolic syndrome. And that is because this chronic inflammation which is happening right from in utero life, and it has already been in place for 15 years before the patients present to us. The first diagnosis of PCOS syndrome in these girls is actually metabolic syndrome and maybe acanthosis nigricans, which is a very scary thing because you and I are actually not properly empowered to understand it, diagnose it, tackle it, and give the right solutions to these women, especially because they have a resistant kind of insulin resistance. Just remember this. We are all familiar with clomiphene resistance, but many of us are not familiar with the concept of gonadotropin resistance. We know that when there is oligo and anovulation, we need to give oral ovulogins. If that doesn't work, the next step is to go to gonadotropins. What you will not be aware if you don't practice infertility and you just practice general OBGYN is that some of these women are resistant even to gonadotropins. They won't respond. And if they respond, they will suddenly explode with ovarian hyperstimulation syndrome. And this is actually because of all these low-grade chronic inflammation and a resistant kind of insulin resistance, which doesn't easily respond to the standard therapies and the standard teaching which has been there in our textbooks and which we have been imparting to our trainees and our juniors as well. Insulin resistance is present in all women with PCOS, whether they are obese classic PCO or they are lean PCO. That is the basic pathophysiology which we were taught when we were students. Okay? Until 2005, 2010, it was considered to be the basic problem or pathophysiology of PCOS. Because there is an insulin resistance, you need to prescribe insulin sensitizers. What we didn't realize at the time is that this insulin resistance also acts on various other organ systems of the body, including the liver, including the pancreas, and one more tissue which we'll come to in just 1 or 2 slides. So this is what I mean when we talk about insulin resistance, and a resistant kind of insulin resistance which doesn't easily respond to the standard therapies which we prescribe. I'm not going to bore you by talking about all the clinical presentations because this is an august audience, but I will focus mainly on the metabolic complications and the hyperandrogenemia and insulin resistance and what other options we can offer our patients. Another concept which has actually gained a lot of traction in the past 10 years is this concept of visceral adipose tissue. If you've heard this before, then this will be very familiar to you. But in 1990, when I was a medical college student, this concept did not exist. I actually understood this and learned this when I was preparing to speak about PCOS. So it's only by continually revisiting the whole idea that even I was informed about this and I was completely clueless about it. And the more you read about it, the more you realize that just like for decades together, human beings fail to recognize that the skin is the largest organ of the body. In retrospect today, it seems very stupid, but it took us many decades to understand this. Similarly, it has taken us many decades to realize that the adipose tissue inside the abdomen, also called as visceral adipose tissue or VAT for short, is the seat of a lot of complicated interactions which are happening, and that is actually the one which gives rise to this chronic inflammation. This chronic inflammation primarily is via various cytokines. Some of them are listed on that slide. They will be familiar to you. You will have read about them, but there are no tests which will be able to conduct in a pathology lab to identify whether this inflammation takes place. Okay? You can measure fasting insulin. Okay? You can't measure TNF alpha. You can't measure interleukin 6 unless you are in a research lab which offers all those complicated, difficult and expensive tests. It's not for the ordinary OBGYN like you and I. And obviously, because we can't do those tests, we cannot actually see what is happening beneath the surface. For example, once upon a time, the test for CPK-MB as a predictor of myocardial infarct just came in when I was a college student or I was doing my MD. Before that, that test was not available. So before that, that entire concept did not exist. Similarly, maybe 5 years from now, you will have tests which specifically measure these inflammatory markers, and maybe there will be scoring systems, and we'll be able to better strategize our treatment in a step care fashion. Until then, we are still a little bit clueless. What we can look at is indirect markers of this insulin resistance, this hyperinsulinemia, and of course, your chronic inflammation. You will have seen this slide in many presenters' presentations, and it's here for a reason. It's here to emphasize that there is a vicious cycle between your hyperinsulinemia, your hyperandrogenemia, and chronic inflammation. and you need to break that cycle at some point of time. That is the sum total of all treatment that you and I can offer our patients, irrespective of whether they come with acne hirsutism, or they come with fertility issues, or they come with endometrial hyperplasia when they are in the perimenopause. You have to be able to break that vicious cycle. And how do you do that? By offering insulin sensitizers. What is the best insulin sensitizer known to man? Physical exercise consistently, religiously, is the best insulin sensitizer known to man. What are the 6 best doctors known to man? Sun, water, light, regular exercise, air and sleep. These are the 6 best doctors known to man. Similarly, the best insulin sensitizer is physical exercise. All drug treatment comes after that. Okay? Unfortunately, physical exercise is easily prescribed. It is very difficult to initiate. Once you initiate, it is very difficult to maintain. And we ourselves as doctors don't set very good examples to our patients. Most of us are quite obese and we are very sedentary. So patients say, doctor, you yourself don't practice what you preach, so why should I listen to you? So let's go to the drug treatment. Now, as far as the drug treatment is concerned, there are many options which are available to us. There are many which are prescribed in our standard medical teaching. I'm here to talk to you about a slightly new alternative or new option which we'll quickly come to. Androgen excess, all of you are aware, the 2-cell 2-gonadotropin theory, because there are too many theca cells. So therefore, from cholesterol precursors, you have too much of androgens which are circulating because your granulosa cells are less. Obviously, there is less conversion of androgens to estrogens. Now, this androgen excess actually, specifically in Indian women, leads to certain problems. It converts the entire body physiology into a male pattern where there is excessive accumulation of truncal fat. Apple-shaped, pear-shaped obesity is all well known to us, and this chronic inflammation and visceral adipose tissue results in a higher free androgen index, more insulin resistance, and a resistant kind of insulin resistance. As I said earlier, we are getting young girls who have acanthosis nigricans at the age of 15 and 16, which is a pathognomonic marker for cancer as well as insulin resistance. And specifically, unfortunately, because of our Indian genes, centuries of high carbohydrate, oily food, there are certain genetic changes in us which make us more predilection towards metabolic syndrome. Now, in the 90s, we were taught by Spiroff and all our textbooks that the main problem with women with PCOS is oligo-ovulation or anovulation. You get them to ovulate, they'll get pregnant, problem solved. Unfortunately, and this is my gray hair speaking after 35 years of practice, I've realized that the situation is not so simple. You can get women to ovulate, but getting them pregnant is a completely different nightmare. And those of you who are senior here and who have treated women with PCOS for fertility know how difficult it is. And today, with the benefit of hindsight and research, we know that this is actually not only because women fail to ovulate, it's also because the oocyte quality is poor, and finally if fertilization does take place, you will find that the endometrial receptivity is poor, which means that you get very good zygotes, but they don't implant, and that entire cycle goes waste. So let's quickly go to the evidence-based management pathways. For adolescents who present with irregular cycles, obviously diet, exercise, lifestyle, you give them the same standard things. Sometimes they work for a short period of time, but later on you will find that beyond a point they don't work. If the woman's age is less than 16, you can offer insulin sensitizers plus withdrawal bleeds once every 3 to 4 months. She should get at least 3 to 4 periods in a year. If it's more than 16, then you are not worried about epiphysis fusing early, and you can put them on cyclical OCs as well. Whether that is going to be well received by the patient and her caregivers, that's a completely different, how can I put it, discussion. Okay, and that's a topic by itself. As far as obese adolescents are concerned, besides our diet, exercise, lifestyle, insulin sensitizers are the mainstay of treatment, and this is also endorsed by the ESHRE guideline. This is not considered experimental therapy anymore. Insulin sensitizers are the first port of call if obese adolescents are presenting to you. As far as adults are concerned, you need to individualize depending on what specifically she is going to present to you at that particular point of time. And we are going to focus mainly on the insulin sensitizers, because the same Gisapeta Purana treatment which we've been dishing out for 40 to 50 years somehow doesn't seem to work in the modern PCOS. Maybe it works for a short period of time, maybe it works in certain select groups of patients. It does not work in all the patients, it definitely does not work all the time. And that's why we need to be able to give these patients new options. And sometime around the time of the pandemic, I came across this interesting new molecule called as berberine. And this has been used for more than 100 years, and you'll be surprised to know that you can actually order it on Amazon. It's a nutraceutical. It's not even considered as a drug. Okay, it's a food supplement. It comes under FSSAI. Okay, just like you can order protein powders, you can order creatine. If you're doing gym, you can order berberine online on Amazon. Unfortunately, the problem is that those preparations are not very pure. They're not very refined, and they don't seem to have consistent results. Therefore, you need good purified drug, and you need consistent results. Now, berberine has been shown to improve menstrual irregularities by inducing ovulation. It reduces the incidence of amenorrhea and irregular menses by 60 to 70% within a period of 3 months. And you'll be surprised that this doesn't only work in obese women, it also works in lean women. And in lean PCO, especially if you've treated lean PCO, it's very difficult to convince the patient that you have polycystic ovary syndrome, because when she goes to Dr. Google online, she sees all these fat women. She can't believe that my body physiology is the same as this. She says, doctor, there's something wrong with you. She'll go and change the doctor, she'll go to someone else. All right. So this is where especially it scores over the traditional therapy which we've been offering our women. And in lean women, there's no point in telling them to exercise and lose weight. They'll say, I'm already fine. Doctor, I think I'm good. There's no point in me exercising. Though even in that class of women, a small weight loss of 4 to 5% will also work wonders. The problem is that they don't listen to you, they are not convinced, and they want medical treatment. So this is one of the options that we can offer them. As far as acne and hirsutism is concerned, it has been proven beyond doubt that berberine reduces your acne and hirsutism significantly by again 60 to 70%. And this GAGS and CADI actually scores from dermatology. Don't ask me what they are because I'm a gynecologist, but these are actually studies done by dermatologists published, and they have found good benefit with this. Now, classically what we have been taught is that the standard treatment for acne hirsutism is either cyproterone, spironolactone, or you can put the patient on drospirenol. Correct? Most of these are OC pills, and many young girls, especially who come to us with acne hirsutism at that tender age, are not very happy taking OC pills, even in the modern world. So this is a good option for those women. This is the most important slide of the entire presentation. I would highly recommend that you take a picture of this slide. Even if you don't take any other pictures, just take a picture of this one slide. This is my take-home message in one slide. Okay. As compared to the traditional therapies which we've been writing for 30-40 years, like metformin, and over the past 10 years, we've now been writing about inositols, whether it's myoinositol or dechiroinositol. Berberine is far superior. It is not only superior, it is better by a factor of 2 times, 3 times, or 4 times. Okay, and this is proven by papers, published research. Now there are 4 important parameters on this slide: weight, body mass index, waist circumference, and waist hip ratio. Now, can anybody tell me? I understand why weight and BMI are there. Why are waist circumference and waist hip ratio there? You're close. You're very close. Very good. Correct. Excellent. So if I can put it to you this way, that once upon a time we used to do fasting insulin levels before we started metformin on a patient. We had to document and prove that the insulin levels were abnormal and therefore we are starting insulin sensitizers. Today it has been recognized even by the WHO that the best marker for insulin resistance is waist circumference and waist hip ratio. The humble tape measure which we have been using in our obstetric OPDs, antenatal OPDs, to measure symphysis to fundal height is still better than home IR and fasting insulin. And that is why this particular slide has those two important parameters. So when a woman weighs herself month after month, that scale may not move much. From 69 kilos, she may go to 68 kilos or 67 kilos. But you look at the waist circumference, it will change by as much as 4 to 5 inches in a very short period of time. And that's exactly what I did, and I will come to that in just 1 or 2 slides. Berberine is better than metformin. That's something which is already proven. It's also better as far as clinical pregnancy rates and live birth rates are concerned. These are small studies, these are not large population data, and that large population data will come when you and I actually use it in clinical practice, and then it becomes part of a guideline. Remember 10 years, 15 years back when the inositols first came in, there was no guideline from Western countries which told us that inositols can be used. We used it left, right and center. We showed that it is useful in Indian population. Today the 2023 HTA guideline says inositols are no longer considered experimental therapy. They are considered at par with metformin. 10 years from now, I don't know what PCOS will be called then, it will have some different name, but maybe berberine will be seen as one of those alternatives just like inositols. Until then, you and I need to use it, generate more data and show that it works in Indian population as well. Minoxidil is well known to you, so I am going to skip past some of these boring slides. I am going to talk a little bit about chromium and melatonin. Remember, we are talking about insulin resistance and we are talking about clomiphene resistance. There is a certain group of women who don't easily respond, they don't easily ovulate, and for them we prescribe insulin sensitizers. The next step after the insulin sensitizer and letrozole is usually to offer gonadotropins. Before you go to gonadotropins, and many women even in today's world cannot afford gonadotropin therapy even though the cost has come down compared to 20 years back, these are a couple of agents which are worth trying. Chromium and melatonin. Melatonin actually restores your sleep cycle. A lot of these women have disturbed sleep patterns. They are doom scrolling at night, if that terminology is familiar to you. There is a lot of exposure to blue light, their circadian rhythm is disturbed, they have sky high cortisol levels, and of course they already have excessive androgen levels, owing to which they have a resistant kind of insulin resistance. So chromium and melatonin are supposed to be beneficial. Minoxidil is known to you. Chromium proven to improve ovulation and clinical pregnancy rate. Melatonin increases your fertility outcomes, especially in women who have a resistant kind of resistant PCOS. Quickly summarizing, berberine, MIDCI, melatonin, and I'll just show you 2 studies which I did in my own population in Bombay, and specifically I've looked at only waist circumference and waist hip ratio. I was able to prove that at the end of 3 months of simple monotherapy with berberine, not with all the other masala that we've been talking about, pure berberine alone, we had more than 5-inch reduction in waist circumference in more than 37% of patients, and 62% had 1 to 4-inch reduction in waist circumference. The next step was to look at ovulation induction. Remember, these are women who have clomiphene resistance. The next port of call typically would be to go to gonadotropins or offer laparoscopic ovarian drilling in this population. Everything else that you try is a stopgap in between, and those were the patients that we examined. We found that these women ovulated with just simple berberine. So what is berberine? It's an isoquinoline alkaloid. It is, as I said, available online, even on Amazon, but that's not the pure preparation. You will not get consistent results, and you will not get results in your population if it is not a pure preparation. What does it do? It works on a specific diet which aims to replicate the same effects that berberine does. Multiple different actions at multiple different levels. and it's supposed to reduce your androgens, reduce your chronic inflammation. It's supposed to inhibit your lipid synthesis, reduces the chronic inflammation that we've been talking about, the visceral adipose tissue that we've been talking about. So it works at the root cause of all the metabolic problems. There are multiple genes through which it acts at a molecular level, and there are plenty of papers in international publications regarding it. Specifically for those of you who practice fertility, remember we said that getting women to ovulate is not the last frontier. The final frontier is to get them pregnant with a singleton pregnancy and a take-home baby. That's where berberine helps. It decreases your LH levels. It improves not only your ovulation but improves your endometrial receptivity through those very difficult to pronounce receptors. Okay, I see Anita is smiling at me, but these are studies which have shown that berberine is a good and effective agent in small studies. Remember, these are small pilot studies. We need to have more and more data, and for this I received the Bombay Society's Best Paper Prize for 2 years, 2023 and 2024, because this was original work. But remember, these are small pilot studies. Until we have more data and large volume data, and we look at the other problems like the metabolic syndrome, we look at the lipid profiles of these women, and we can prove in the long term that it improves not only clinical pregnancy rate but live birth rate, then the proof of the pudding will really be in the eating. Okay, but that will not happen until you and I start prescribing it more, using it more, generating our own data and publishing our own data. So I'll conclude by saying, ladies and gentlemen, that this is a promising new agent. Here, as far as Beritol is concerned, which has been introduced by Blissin, there are multiple other agents which are proven to work in resistant kind of PCOS, including chromium, including melatonin, and there's also MI and DCI. Last two slides, GLP-1 agonists are a promising new agent which is available, recently launched, and I think you've had CMEs in Delhi also. I was invited to one of them, but unfortunately I was double booked. So GLP-1 RAs are a good option. At ISAR, we have done a very nice guideline which was published in August of 2023, which looks at the role of GLP-1 RAs specifically in women who have obesity and fertility. And as we said, most women are obese and have PCO. So in this particular population, if you have a BMI of 27 or more with one comorbidity, you can start GLP-1 RA. If you have a BMI of 30 or more without a comorbidity, again you can start a GLP-1 RA. They are not safe in pregnancy, so once the target weight is achieved, you have to stop them, and then you can proceed for fertility treatment. There's a very nice guideline on acanthosis nigricans done by Dr. Duru Shah, President of PCOS Society. I was one of the people on the guideline development group. Again, this is published in 2023 and it's freely available on the internet. I'll close by saying that PCOS is now the new pandemic. The PCOS that we see today, probably the name will change in the next 1 year, is very different as compared to the PCOS that we encountered when we were medical college students. A lot of new theories have come in: visceral adipose tissue, chronic inflammation, hyperinsulinemia, resistant PCOS, clomiphene resistance, gonadotropin resistance, and all of these require new tools for this new age monster which we are trying to fight. I'm not saying that the old tools don't work, but they don't work all the time. They don't work in all the populations all the time. And for this select group of patients who are coming to us and seeking help, we need to be able to offer new solutions, something different, something which is more likely to work before we put them on the final common pathway of IVF and that entire factory assembly line, which is a different discussion altogether. So patient-centric approaches and evidence-based management is the key. And later on, over a period of time, once we have better tests to look at inflammation like interleukin-6, cytokine levels, so on and so forth, and put that into an AI algorithm, we'll be able to better target these women, and in a step care fashion, we'll be able to evolve our management more. Whether I will still be alive then or not, I don't know, but hopefully whatever I have said today has added to what is your existing knowledge. The secret of change is to focus all your energy not on fighting the old, but building the new. Thank you for a patient hearing. Incidentally, I am contesting for the post of ICOG secretary. So those of you who are fellows, requesting you humbly to please support me and vote for me. The election will be between 1st and 10th of September this year. Thank you again.